All right, we're gonna roll towards you on the number 3. 1, 2, 3.
I'm Dr. Walpert. We're going to be taking care of you today. I know there are a lot of people around you and it's scary, but we work as a big team.
I thought it might have been a little bit heat related, but his tachycardia never came down. It stayed sustained.
I suggest we transport him, get some fluids on him hydrated.
What's up, bud?
I'm just dizzy.
Okay.
I don't know why.
All right, you feel like you're going to pass out?
Yeah, I just feel real weak.
Real weak?
Yeah.
Okay, let me get a pulse real quick on you.
If I'm not suspecting trauma, I'm simply going to go to a head tilt, chin lift.
Hello, my name is Dr. Jim Kyle. I'm the Emergency Department Director at Beckley's Appalachian Regional Emergency Department and head team physician for Concord University. I look forward to spending the next few minutes discussing with you the issues of vital sign trending in sports trauma. As many of you are aware, we're seeing an increase in some sports trauma trends over the last decade. Heat stress injuries are up, asthma emergencies seems to be going up, and more emphasis on the terrible tragedy of sudden cardiac arrest for a combination of previously unrecognized congenital conditions and one of the new issues happening, the cardiac concussion or Little League Baseball sudden death. I would like to note that the heat stress injuries in our region have seemed to be going up regionally. It could be because of hotter August days during two-a-day football practices, but in addition, widespread availability of performance-enhancing drinks and they're being used by athletes of all ages. And in addition to this, the new emphasis placed this year in 2012 on the potential of sickle cell trait contributing to serious cases of heat illness. Sports trauma management and this presentation on vital sign trending in sports medicine trauma cases is actually about a 15-year-old initiative. It started in the 1996 Olympic Games at Olympic Stadium, where Ron Corson, as many of you know, is head trainer at the University of Georgia and initial author of Athletic Training and Emergency Care. And I participated in the care of these elite athletes, world-class athletes at Olympic Stadium. It was projected to be very hot in Atlanta in the summer of 1996, and it was. We had to be ready for a variety of emergencies, and interesting enough, we weren't equipped at Olympic Stadium because of staffing issues with the typical first-line people you would expect in cardiac or collapse athlete emergencies. We didn't have any ER nurses, any paramedics on our staffs, but what we did have was a talented group of athletic trainers, mainly concentrated in the southeastern United States. What we learned there is that we could take good care of athletes, similar to what we've done in the past at the NCAA Division I level when sports trauma occurred. The challenge for you and your system, in addition to providing care for elite athletes in your region, is how do you provide the same care using the principles of sports trauma management to the high school or junior high level? As you can see here, this famous Georgia football player, Fred Gibson, started at a very much smaller profile spot, the junior high football field in Waycross, Georgia. How can we make sure that what's provided on game day in Athens, Georgia to the Bulldogs is also provided on the junior high or high school level in rural areas throughout the country? As many of you are aware, West Virginia is classified as a rural state. We have lots of small schools, and our mission is big. We need to provide the same type of teamwork and healthcare delivery on game night, Friday night lights, if you will. And I would challenge you that the way to approach this is to make sure that you have a solid triad of talent available on game night. Certainly the athletic trainer the NATA certified trainer is a luxury in some parts. The ATEC course that you're learning about today and in other presentations provided by the Andrews Institute provides the format for game day readiness for the athletic trainer. If your trainer is ATEC certified, EMS is available with the ambulance on scene with ACLS, Advanced Cardiac Life Support Talent, and your team physician has been exposed to Advanced Trauma Life Support, ATLS. I would suggest that you're ready to go and have a solid foundation for success in sports trauma management. So today what we're going to talk about in vital sign trending are the following topics: how to approach initial vital signs, the rule of 100, more about that in a minute, and then we'll look at vital sign trending, taking the initial vital signs, repeating them during intervention in cases of the common heat stress, the unconscious or down athlete, and asthma attack. Finally, we'll talk about when to worry, pearls of how to approach that when it occurs and what to do next, and finish up with a listing of those sideline gadgets that you'll want to have available to provide these services. So our vital sign trending goes something like this. Initial vital signs are done when an athlete sustains sports trauma. After those initial vital signs on the field at the time of the initial assessment, I want you to be able to perform a rapid rule of 100 assessment. After that rule of 100, vital sign trending over 30 minutes. If the athlete's in distress, the rule of 100 is repeated at the end of the 30 minutes with the decision whether to activate the EMS system, transport the athlete to the emergency department, or return the athlete to the training room for team physician evaluation. So on initial vital signs, we have first the pulse. Pulse, normal definition, is a heart rate between 60 and 100. I would suggest that an easy way to calculate this on the downed athlete is to take a 6-second count, add a 0, and that's the heart rate. For example, if I take my own pulse now, radial pulse, watch for 6 seconds, the number's 8, so my heart rate is 80. Counts above 10 means that it's tachycardia. A heart rate greater than 100, counts more than 15 are for concern, heart rate of 150. Lower heart rates, be aware, can be common, particularly in the conditioned athlete. So our first pearl for vital sign trending, expect the heart rate in sports trauma to be less than 140. If there is no radial pulse, check for a femoral pulse in the groin and activate the EMS system. Keep in mind that for every 1 degree increase in body temperature, your pulse rate increases by 10 beats. And once again, remember that the conditioned athlete may have resting heart rate under 60. Initial vital signs, blood pressure. The systolic blood pressure must be about 90 to 100, the systolic blood pressure being the top number, in order to be able to palpate the radial pulse. So the presence of a radial pulse tells you that the blood pressure probably is in the range of at least 100. As soon as it's available, a sideline blood pressure reading with a typical blood pressure cuff should be obtained. Beware of a narrow pulse pressure, in this case 120 over 100, the pulse pressure being the difference between the top and bottom number. More about the significance of a narrow pulse pressure later. And finally, the blood pressure for femoral pulse requires at least a pressure of 70 millimeters systolic. And finally, initial vital signs for temperature. Tympanic oral temperatures greater than 100 degrees suggest heat stress. The NCAA and NATA position statement for rectal temperature monitoring in athletes with extreme stress is important to pay attention to, even though most of the time the tympanic or oral temperature will guide you into the need for using the rectal temp. As most of you are aware, heat stroke occurs with temperatures accelerated up to the 103 to 105 range. So now I hope you have a little feeling about your ability to take initial vital signs and interpret them accurately. The next point is the rule of 100. The athlete has suffered an injury or has demonstrated stress on the playing field. Let's apply the rule of 100. If the pulse, radial pulse taken, is greater than 100, if the temperature is greater than 100, or if the systolic blood pressure is less than 100, the rule of 100 exists. Vital signs trending should be initiated if any one of these three are positive. During the time of vital sign trending, serial vital signs will be taking 5-minute intervals, monitoring the heart rate, the blood pressure and the temperature, in particular the response to your intervention, be it resting, hydration, cooling interventions, checking to see how the athlete responds to the stress. Now, I can tell you that we do this daily in the emergency department. If you come to most emergency departments and have a significant complaint, you're hooked to a cardiac monitor, a pulse oximeter is placed on your finger, oxygen is delivered, and the monitor tells the story of vital sign trending. Each time a physician or nurse goes into the emergency department room to evaluate your progress, the heart rate and blood pressure are displayed, and very helpful in understanding if your intervention's making a difference in the patient care. The same type of vital sign trending occurs during transport during EMS activation. Monitors are attached to the patient, giving an ID where the medications given had the desired effect. After the vital sign trending period of 30 minutes, the rule of 100 is once again applied to determine if the numbers have returned to normal. For example, if an athlete had a pulse of 140 and then during the course of vital sign trending, after hydrating and treating for heat with ice pack application, the heart rate returns below 100, he would be seeing the team physician in follow-up. However, if the rule of 100 was still in effect after 30 minutes, the athlete should be transferred to the emergency department. Well, now we've applied the rule of 100, it's time to do vital sign trending. This is the fun part of the evaluation. We're going to look at vital sign trending in respect to what happens to the pulse rate, what happens to the blood pressure, and what happens to the temperature if things are going well. So let's think a little bit. Tachycardia, heart rate greater than 100. You're hoping it's sinus tachycardia, which is good, and you don't want it to be the other two. SVT is bad, VT is ugly. So the good, bad, and ugly, sinus tachycardia, supraventricular tachycardia, bad, ugly, VTAC. Sports tachycardia, I would say to you, this is how it acts. Heart rate's fast, you would expect it in vigorous sports play. Your initial vital signs show a heart rate 130, 140, maybe even 160. Over 15 minutes with your intervention, you can expect that heart rate return to below 100, therefore not violating the rule of 100s. Persistent tachycardia, that heart rate that remains up particularly in the 150, 160 region, is time for your sphincters, if you will, to start to tighten. Cardiac monitoring will be required. Supraventricular tachycardia or VTach could be present. During this time of vital sign trending, a simple formula to remember. If your volume is down, if your stroke volume, the SV is down, the heart rate has to go up to maintain the cardiac output. As you provide more intravascular volume, either by aggressive oral or intravenous hydration, the heart rate should come down. If it doesn't, it's an issue. How about low heart rate? Pretty uncommon in sports play with trauma. The most common reason would probably be the athlete is really not in much trouble and they're conditioned and their heart rate's 50, you don't need to worry. Less common, the Cushing response to head trauma, we'll talk more about that later, as well as spinal trauma issues with loss of sympathetic tone. One unique cause of bradycardia in the athlete is the adult cardiac concussion. As most of you are aware, commotio cordis cardiac concussion was first described in the literature in the late 90s. Dr. Mark Estes described in the New England Journal of Medicine in 1998 through animal studies that baseball hitting a young chest at just the right time at the upstroke of the T wave, as you can see in the red area on the slide, results in ventricular fibrillation. Early defibrillation with an automated external defibrillator can be and usually is life-saving. But what happens if the ball strikes during the QRS complex? As you can see, the red arrow in this slide pointing to a strike at that point. During the animal studies, 3 things could happen. Third-degree heart block, a new left bundle branch block, with or without ST segment elevation. So an athlete struck in the chest playing football as the receiver comes across the middle and is hit with a bit of enthusiasm and vigor by the safety in the chest that collapses. Everybody on the sideline assumes he got the wind knocked out of him. Perhaps he's actually had a QRS commotio event, cardiac concussion with bradycardia. Be sure to check that pulse as soon as you get there. A slow pulse rate would demand emergency attention and transport to the emergency department for further evaluation. That concludes the information on pulse in vital sign trending. Now let's think about blood pressure. Low systolic blood pressure, numbers below 90, are rare in sports trauma. High blood pressure rarely needs treatment. Now, as we think about the combination of pulse and blood pressure, let's think just a minute about the rate pressure product, RPP. Taking the top number blood pressure and the heart rate, multiplying it, when it remains above 20,000, it's of significant concern. This principle is utilized when adult patients are subjected to stress testing. So my message here is if you have an elevated blood pressure and an elevated heart rate and it continues, your athlete is actually undergoing a stress test. Do the numbers. A blood pressure, say, of 180, a heart rate above 100, that's pretty close to the 20,000 number that we mentioned. So in combination of those two, pay attention and trend it. Acute blood loss results in a series of events that you need to be made aware of. First, the heart rate goes up. Second, the pulse pressure we discussed earlier. The difference between the top and bottom number narrows. And finally, the blood pressure goes down. I can tell you that our trauma team at our hospital emphasizes this point to us time and time again. Mr. Scott Hell recently gave a talk to our nurses saying in a typical 10-year-old with significant hemorrhagic trauma in a motor vehicle accident can lose 50% of their blood volume before the blood pressure ever decreases. If you wait on the blood pressure to decrease, you've waited too long. Look for the tachycardia that's persistent together with a narrow blood pressure. Systolic blood pressure less than 90 equals shock. Shock is bad. And if it happens to you, I go, oh my, what am I going to do? Remember this mnemonic. Shock is bad. B-A-D. It could be from B, blood loss, A, arrhythmia, or D, dehydration. More common in the sports setting. What are you going to do about it? Oh my, go get the doctor. In the meantime, oxygen, monitor, cardiac monitoring, and IV. Shock is bad. Oh my. Now finally to vital sign trending in reference to body temperature. As we all know, the temp is dependent on the climate and the clothing. During August football and endurance sports, it's not uncommon to have high temperature, ambient temperature, and resulting in increased chances of heat stress. But generally speaking, athletes should be able to recover from this with 30 minutes of good hydration and cooling. After 30 minutes, if the temperature is still above 100, the rule of 100 is in effect, and the athlete needs more definitive evaluation. Now let's try to put it all together. Our initial vital signs, our Rule 100, and vital sign trending with the examples that you might see during your next season with your athletic programs. Heat stress, asthma, and the unconscious athlete. Vital sign trending and heat stress. Now, the terminology for heat illness, as you're aware, is a little bit complex in the sense that mild dehydration, heat exhaustion, heat syncope are all thrown in on one side of the spectrum, heat stroke at the other side with elevated temp. But generally speaking, most sports medicine physicians would agree that heat exhaustion, the vital signs would be something like this: a pulse slightly up, 120, a blood pressure that's still systolic above 100, and mild elevation in the temp. If this occurs, cooling, ice bags, and fluids, probably oral fluids in the amount of 500 to 1,000 cc's will be your first line of treatment. After 30 minutes, because of the pulse being elevated, Rule of 100s, vital sign trending over 30 minutes, you'd expect the pulse to come down below 100 and the temperature also to be below 100. If the athlete is unable to take fluids, gets nauseated and vomiting, that becomes a red flag. I'd like to share with you now a scenario that could happen to you. This Concord University athlete was involved in strenuous exercise on a hot August day and complained to the training staff of feeling weak and dizzy.
You all right, Zach?
Hey,
What's up, bud?
I'm just dizzy.
Okay.
I don't know why.
All right, you feel like you're gonna pass out?
Yeah, I just feel real weak.
Real weak?
Yeah.
Okay, let me get a pulse real quick on you. Did you eat breakfast this morning?
No.
Okay. All right. Are you good to walk over so we can get you off your feet?
Yeah.
Okay.
This athlete had been previously tested and found to have sickle cell trait.
All right, let's get you seated here. All right, if at any point you think you're gonna pass out on me, you let me know so we can get you laid down and get your feet propped up, okay? All right, your pulse was high on the field. It was about 140. That's pretty high for you. So we're gonna retake it over here, and we're also gonna go ahead and get your pulse ox. Scott's taking your temperature, and he's gonna get your blood pressure, okay?
That's 99.
Okay, so your temp seems like it's good, so we're not gonna worry too much about overheating, okay? Do you feel shaky at all?
A little bit.
A little bit?
Yeah.
Okay. All right, pulse ox is 98, so that's good. Your BP, or I'm sorry, your pulse is still up there, okay? So we need to try to get that down. So just try and deep breath, try and relax for me. I'm gonna get you some water, see if we can get you drinking.
(130/70).
Okay. Zach, we're gonna try and get some water in you, okay? So don't take really big gulps, but try and just take some small sips for me, okay? You all right, bud? Did you get it all up? Okay. Can we get you back down?
Yeah.
All right. Scott, if we're not going to be able to keep fluids in him, I think we should probably go ahead and get an ambulance here.
I'll go get it.
Yeah. Doing all right? Can you open your eyes and let me know how your vision is? Do you have double vision or anything?
No, man, just blurry.
What happened to him?
Blurry?
Just feel weak.
What's going on?
Well, he was out doing drills and he started feeling a little bit dizzy, lightheaded. So I took a pulse. It was 140 on the field. We came over here. His blood pressure seems fine.
Look at me, Zach.
He didn't eat this morning, but he's not real shaky. He is a sickle cell trait athlete. His pulse ox was good, 98.
We got to get an IV in him with this stomach issue.
Okay, let's get his pads
IV,
off.
close off. Okay.
You need an IV on this guy?
Yeah, he was having some trouble on the field, dizzy, lightheaded. His pulse was up to about 140 on the field. That was about 15 minutes ago. We've retaken it, it's down to 95. So pulse is okay. His blood pressure was 140, top number to start out with. Now it's 130, but he is a sickle cell trait athlete and he's not holding oral fluids.
What's your name, bud?
Zach.
Zach, I'm gonna start an IV on you, okay?
Okay.
Guys, when you do the squeezing in, we need 1,000 cc's quick. Get a liter of normal saline in quick on this guy,
Okay.
okay? Let's transport him to the hospital. I'll meet you
right.
there.
You doing okay, Zach?
Yeah.
Okay.
Is it gonna hurt?
It's gonna pinch a little bit. Okay, just hold your arm out straight for me. We'll feel a little pinch here. Okay.
The vomiting was the red flag, necessitating consideration for intravenous fluids, normal saline bolus, in particular with his history of sickle cell trait.
Just run that wide open. Zach, it's gonna make you feel better, all right, buddy?
Thank you.
Let me check your IV here. Make sure everything looks okay. They start this on the field when this happened? Okay.
Jennifer, what happened was during drills on the field, he started feeling a little bit weak and dizzy, so we pulled him off and got some vitals. His pulse was 140 on the field, so we took him over and sat him down, tried to orally rehydrate him, and he wasn't able to keep it down. He started vomiting. His pulse did calm down to 95 about 15 minutes later, but he is a sickle cell trait athlete.
Okay. Okay. How are you feeling right now?
I just feel sick, dizzy.
Are you sick to your stomach?
Yeah, my stomach hurts. I think
Okay.
I might throw up again.
Okay, we'll see if the doctor can give you some medicine.
Okay, all right.
All right. Zach, they're going to come and take your blood, okay? Okay. How are you with needles?
I hate needles. I may pass out.
Can you tell me your name and date of birth?
Zach Grossi, September 25th, 1989.
Just look at me while she's taking your blood, okay? It'll help keep your mind off of
Be
it.
careful.
So, in the past week or anything, has anything been wrong with you? Have you had a sore throat?
I just got over a sore throat.
You did? Yeah. So in the past week you've been sick?
Yeah, about a week ago.
Okay.
All right, little stick ready.
Yeah.
You're doing good. Just try to relax.
Blood tests obtained in the emergency department needed to determine whether or not the athlete had electrolyte issues or any elevation of his CPK, creatinine phosphokinase. Severely elevated levels of CPK are associated with rhabdomyolysis.
Zach, I'm going to need you to give me a urine specimen, okay? What I need you to do is just put it in this cup, and once you're done, put it back in the bag.
Okay, could you help me to the bathroom?
I sure can. All right.
The urine test needs to also be done in this situation to determine if dipping the urine, the dipstick, is positive or negative for blood. A positive dipstick implies early rhabdo. A negative dipstick excludes the diagnosis. This scenario demonstrates the appropriate approach to an athlete with suspected heat stress, sickle cell trait, needing IV hydration. It'll be safe in this case to have the athlete discharged from our emergency department, follow up with the team physician in a timely manner. So now let's look at vital sign trending in the case of asthma. Lots of athletes have asthma. In the case of junior high athletes, maybe 10 to 15%, with decreasing numbers in high school and collegiate athletes. The initial vital signs, heart rate will be mildly elevated, and the peak flow measurement, the handheld blow device, you'd expect it to be somewhere between 400 and 600 liters per minute. Pulse oximetry, fingertip pulse oximetry should be in the high 90s. Athletes having an asthma attack should receive a meter dose, inhaler dose of a bronchodilator and repeat the peak flows, expecting things to get better in about 10 minutes. Very low peak flows, get some oxygen, and make sure you know what the baseline peak flow is for all your athletes with existing asthma. Common sense move. Now let's talk a little bit about pulse oximetry. Pulse oximetry is the amount of oxygen saturated to the hemoglobin molecule, measured through the capillary bed. Normal values are in the high 90s. Less than 90 are critical and require oxygen therapy right now, or STAT. Let me repeat, an O2 sat of 90 is BAD bad, ugly. The reason you need to understand this is that the relationship between oxygen in the bloodstream and the O2 sat, a different measurement, hemoglobin molecule saturation, is not linear. An O2 sat of 90 is actually an oxygen concentration in the blood of 60, upside down 90, and it's bad. At the very top of the curve, the amount of oxygen in the bloodstream and the O2 sat are very similar. Not much difference between 96 and 98 O2 sat. Big difference between 90 and 92. Less than 90 is bad. Now let's think about adding the O2 sat to our rule of 100s. In addition to pulse and temperature and blood pressure, now if the O2 sat is not nearly 100, it's a cause for alarm. This is the asthma protocol that Mr. Corson and I used during the 1996 Olympic Games. We had several athletes with asthma. We knew who they were, and we watched them closely. We decided once they identified themselves as having a breathing issue, unusual shortness of breath, cough, persistent, we'd place them in our high priority trauma rooms, either trauma bed 1 or 2, located close to where they exited the field of play. The saturation was done quickly. We placed them all on cardiac monitors. Peak flow was measured and recorded and put on the board. We offered face mask, which was 100% oxygen if they wanted it. Many athletes don't like the idea of a mask over top of their face. They were offered an albuterol meter dose inhaler. Most took it. If they didn't improve after 10 minutes, we repeated the vital signs and considered nebulized therapy and repeated the peak flow at 15-minute intervals. It worked in Atlanta very well in 1996. Now let's take a look at a potential scenario at your school occurring during a high school track meet and see if these principles in 96 still hold true. This sophomore athlete is participating in the 800 meters early in the spring in West Virginia.
What's wrong, dear?
I think I'm having an asthma attack.
Has it ever happened before?
Yes, my doctor diagnosed me with exercise-induced asthma.
Okay, well, come on over here. Sit down and we'll check you out here for a minute. Come here, have a seat down here, hon. Sit right there. Let me take a few signs here from you. Have you ever used one of these before?
Yes.
Go ahead and blow on that. Oh, we got about 300 liters per minute. Let me get your oxygen saturation, dear. Put your finger right in here. All right, try to breathe slow. Oxygen sat is 94% and pulse is 110 beats per minute. All righty, here. I'm sure you've used this before. I want you to take 2 good puffs of this. All righty. Now just sit there a minute. We're going to recheck in again about 5 or 10 minutes. All righty. Do you think you can walk over to the bench here so we can get you out of the plane area? All righty, come on over here and help you, and we'll get some more vitals in about 5 or 10 minutes. Sit down, and I'll recheck your vitals in about 5 or 10 minutes and see how you're doing. Go ahead and sit up on the top here for me so you have a little bit more room. All righty. See how that nebulizer does, and we'll check everything in about 5 or 10 minutes. So how you feeling now after that nebulizer treatment?
My breathing slowed down.
All right, well, let me check your vitals one more time for you before we release you to go back to activities. I'm gonna take your blood pressure here quick. (110/60), that's good. Let me check your oxygen and pulse again. Put this on your finger for me. O2 sat's up to 97% on room air, and your pulse is down to 76 beats per minute. Let's check your peak flow again. Give me 1 good blow in there. All righty. Oh, good. Peak flow liters per minute's up to 510. 1 more blow for me. Let me reset that for you. Okay. (510) again liters per minute. You're good. One more thing I want to listen to make sure your lungs are clear before we release you. Can you take a deep breath and blow out of your mouth, please? Another one. 1 more. All righty. Lungs are clear bilaterally, and the apexes, you're doing good.
Vital sign trendings were applied. She got better. O2 sat went back up. Peak flow improved. It's okay for return to play.
What we were doing is vital sign trending, which indicates see that you've gotten better from when you had the asthma attack to this time, and everything's normal. Everything fits into our criteria, so you can go back in and finish the relay race.
She obviously is doing better if you look at the smile on her face as she returns to play in the relay event 4x400. Now let's talk about the unconscious athlete. Vital sign trending, and that's carry cases of the true downed athlete. Head injuries, C-spine injuries, or the dreaded cardiac arrest. In head injuries, you might see, even though it's typically late in the progression, the Cushing reflex with a decreased pulse, but an increased blood pressure. Talking about blood pressures in the range of 200 systolic and a pulse of 40. Same thing can happen in a severe neck or spine injury with spinal shock, but this time the blood pressure will actually match being low with the pulse. course, in a cardiac arrest, there might not be any pulse, and be aware, if we've talked about in other series here at the Andrews Institute, they may start with a sentinel seizure. It might appear to be a head-related injury seizure and or a first-time seizure in an athlete during participation, but when a seizure occurs, assume that it could be cardiac arrest. Concussions occur frequently. Most concussions are not associated with loss of consciousness, and the focus now in America football is to make sure that a sideline evaluation is done, as seen on the slide, to make sure that the athlete has good cognitive skills before returning to play. Many states now have legislated the return to play being based on team physician availability. Typically, this is done in a very systematic fashion. But how about the unconscious athlete? Rare, but can occur. The Glasgow Coma Scale should be done as soon as possible, understanding this GCS range is from 3 to 15. A 2-point drop in the GCS is indicative of an epidural hematoma. Let's think of a scenario that might occur: bicycle sport, falling, hitting the side of the head, dazed in the beginning, much more confused with difficulty speech or weakness on one side within a few minutes. That's bad. That's an epidural hematoma until proven otherwise. The other side of the equation, falling off the bike, being almost unconscious, hard to arouse, but better in 15 minutes, that's what you want to be seeing. Keep in mind that Glasgow Coma Scales of 8 or lower require respiratory control with intubation, supplemental oxygen, so certainly if you have a low number, it's time to call for EMS support. Now I'd like to spend a little time with you putting this all together. Our initial vital signs, Rule of 100, vital sign trending pearls. Another way of saying it, how to avoid dog bites when playing between the hedges in Athens, Georgia. This Auburn athlete obviously didn't know how to avoid the bite. Want you to, when to worry, when to be concerned. These key points: no absence of a radial pulse, persistent tachycardia, blood pressure that's going down, elevated temperature despite trending, vomiting fluids, 2-point drop in the Glasgow Coma Scale, peak flows that are low, or that dreaded pulse ox under 90. First of all, absence of a radial pulse. No radial pulse, blood pressure less than 90, the patient's in shock. Remember, shock is bad, B-A-D, and what are you going to do for it? Oh my! Oxygen, monitor IV, EMS backup. Shock is bad, but worse than no radial pulse is absence of any pulse. After taking the radial pulse, checking for femoral pulse, the athlete's unresponsive, has had a sentinel seizure, agonal respirations, it's time to make sure and get the AED in place, hoping if the athlete truly is in arrest that it's a ventricular fibrillation that will respond quickly to defibrillation. This must be done in a rapid fashion. Shock times under 3 minutes are desirable. Another reason to worry when between the hedges is persistent tachycardia. The athlete that has a high heart rate during the course of vital sign trending and interventions remains high, particularly above 150. In these situations, you must have a high index of suspicion for supraventricular tachycardia, such as Wolff-Parkinson-White or other reentry tachycardias. The dreaded ventricular tachycardia is very serious. These can only be diagnosed with cardiac monitor on site and utilizing the principle of oxygen monitor and IV. Now let's take a look at another scenario that could happen to you involving persistent tachycardia. This athlete is involved in preseason drills on a hot August day. Initial vital signs showed his heart rate above 150.
Hey, Scott! Scott! Scott, I can't breathe.
What's up, bud?
I can't breathe.
What's going on? Go on, have a seat. Have a seat. So what's going on?
I got a chest. I can't breathe.
Take a couple deep breaths for me, okay? All right, let's check this out here, bud. Ease up.
I can't breathe, Scott. My chest. I got it.
All right, did you hydrate this morning?
Just a glass of water with breakfast.
You peed today?
Twice before practice.
What color is it?
Just pee like light yellow.
You drank more during practice?
Just normal, just water breaks.
All right, you're pretty warm. Let's get you over here and get you checked out. All right, bro. Let's get you over here. All right, have a seat right here. Turn towards straight. All right, have a seat.
It's not getting better. Scott,
All right, take
it's
a
not
deep breath.
getting
Let's get
better.
his blood pressure, okay? All right, man, your heart rate's kind of fast. You're kind of hot. I think that might be part of the problem. Let me get blood pressure cuff. Let's check his temperature, too. Look out. There you go, bro. Couple deep breaths, in through your nose, out through your mouth. All right. Couple deep breaths.
Hey, Jimmy, I'm just going to take your temperature.
Right. Systolic's 150. 100. Let's start cooling him down a little bit. He's tachycardic, I think, because he's hot. All right, we're going to move you up here and start cooling you down a little bit, okay?
I need help.
All right, we'll help you.
Yeah.
He's
On my back?
spin around this way. Yeah, lay on your back. Lay on back. Try to take some deep breaths, okay? We'll put these under your arms, okay? Try to hold that there and hold it in there, okay?
Jimmy, I'm going to put this under your knees.
All right, let's take your pulse again here now, okay?
Scott, it's not getting better.
I know, bud. Just try to relax a little bit, okay? All right, let's get your pulse here. How long have we been into this? About 15 minutes? All right, he's still about 156. We need to get the MS up here and get him evaluated. I think it's sustained tachycardia. I don't think it's heat related anymore.
We've got him right over here.
What do you got, Tracy?
Well, we've got his pulse at 156, his
Okay.
systolic blood pressure at 150, and his temps at 100. We thought it was heat at first, but his heart rate just,
Staying up?
yeah,
Okay. So 156 systolic was what?
150,
Okay.
and his temp was 100 last time we took it.
Jeff, get the monitor on him. John, go ahead and put him on a little bit of O2, about 2 liters, okay? Okay. What's your name, buddy? Jimmy, has this ever happened to you before?
Yeah.
Has it?
Yeah.
Mostly when you're exercising, or?
I mean, I don't say anything. I don't want to get off the field.
Okay. All right. Turn that on there. Put him on 2 liters there, John.
Okay.
Okay. Scott looks like either SVT or maybe sinus
It's a narrow
tach.
complex tach, no
Yeah,
doubt.
narrow complex tachycardia. So how long's he been laying down and resting now?
20 minutes.
20 minutes, okay. Yeah.
We thought it might have been a little bit heat related, but his tachycardia never came down. It stayed
Yeah.
sustained.
I suggest we transport him, get some fluids on him, hydrate him.
I agree.
Here, guys. Jimmy, we're going to get you loaded up there, buddy. Take you to the hospital, okay? See if we can't figure out what's going on, all right?
We'll let him stand. Just go down.
Yeah, just go ahead and lower it down.
The athletic training staff has done a great job of the initial assessment of this stressed athlete. Initial vital signs demonstrated a rapid heart rate with good O2 sat,
Swing your legs over this way.
a radial pulse that's strong, so there was no real evidence of hypotension.
Take your time.
During the vital sign trending portion of their care, the heart rate has remained elevated. Heat stress is probably the most likely diagnosed since this is August preseason two-a-day football camp. If it is heat stress as the cause of the tachycardia, sports tachycardia situation usually results in resolution of the fast heart rate within 10 minutes or so, particularly if the athlete's able to cool down and take some PO fluids. In the back of the training staff's mind, they're considering whether this is a case of sustained tachycardia. In addition, they might be concerned that since his heart is pounding, he might have some anxiety related to it, but he is an upper-class athlete and has been exposed to this situation before. The emergency medical services team has decided to transport the stressed athlete to the nearest emergency department. Transport time is under 5 minutes. One of the key priorities is to establish an IV line and initiate a fluid bolus, usually about 500 cc's. During the transfer, they've been able to give the bolus and his heart rate remains elevated.
Jennifer got a 23-year-old male in football practice. They thought it was first heat related, but he's had some persistent tachycardia, about 160. Blood pressure's okay, 150 systolic.
The team has notified medical command in transferring the patient to the hospital, and the trauma suite has been prepared. The reason for choosing a high acuity room in the emergency department on this athlete include the fact that he's had some chest discomfort, chest pain if you will, and shortness of breath, a very rapid heart rate, all coming on during sports play. This remains a high priority patient, and the ED team will assess him in a very rapid fashion. The most important concept to remember in the ED is that vital sign trending continues throughout the stay.
Scoot right over here in this bed next to you, okay?
Okay, Jimmy, I'm going to place you on this monitor. I'm going to put these electrodes on your chest, and this will show up on the screen what your heart's doing right now. She's going to do an EKG on you, okay?
As the EKG is being done, the athlete remains tachycardic.
Deep breaths in through your nose, out through your mouth.
The nature of his tachycardia appears to be a narrow complex tachycardia, meaning that the QRS complex is of normal length as opposed to a wide complex tachycardia, a more serious cause of problems.
How you feeling, Jimmy? When did it start?
Just in the middle of practice, like all of a sudden we were just doing drills and then I just couldn't breathe.
Have you ever had this before?
It's happened a few times before. I just don't say anything because if you don't practice, you don't play.
Oh my gosh. It looks like you have supraventricular tachycardia. Do you know what that is?
I have no idea what that means.
When was the last time you saw a doctor?
Physical before season started.
Did they not do an EKG?
I don't think so, no.
No? Okay.
Just a standard football physical.
Just a standard football physical, okay. Are you having any chest pain right now?
Right now.
Are you feeling sick to your stomach?
Not so much, just my chest is just coming in.
All right, we're going to do our best and take care of you, okay? Just you need to remain calm, all right?
Despite IV fluids, his heart rate remains high.
I'm just going to check your pulse here, okay? Go ahead and lay your arm down there. She's going to take your blood, okay?
I'm from the lab and I'm going to get some blood. Can you tell me your name
I'm Jimmy.
and your date of birth?
3389.
Okay, just relax.
Jennifer, I'm actually starting to feel a little bit better.
You are? Okay.
It's not pounding as much as it was.
Okay. It's actually starting to slow down. Your heart rate now is 72. That's normal. Try to relax. Take deep breaths in through your nose, out through your mouth, okay?
Appreciate it. The comfort's definitely starting.
Just after having his blood drawn to check for CPK and electrolyte abnormalities, he spontaneously converts to normal sinus rhythm with a perfect heart rate of 72. His CPK is 800, elevated, but not in the range of rhabdomyolysis as confirmed by his negative urine dip for any blood. This athlete should be admitted to the hospital for telemetry to make sure that his tachycardia doesn't recur. Cardiology consultation will be needed to determine if this re-entry tachycardia needs advanced treatment and possible ablation therapy. Other reasons when to worry when between the hedges include a falling systolic blood pressure because of severe dehydration or blood loss. Remember your mnemonic BAD and oh my. A temperature that remains elevated at 30 minutes implies the athlete is suffering from significant heat stress. And as we saw in our first scenario a little bit earlier, the inability to take fluids is a call to action. Any 2-point drop in the Glasgow Coma Scale is a harbinger of potential injury to the brain, including epidural or subdural hematomas. Athletes that are fine at the beginning and then deteriorate rapidly must be transported quickly to the nearest trauma center. And finally, in the case of the asthma athlete, if you find that the peak flow is less than 300 or the pulse ox is less than 90, UGA has officially sunk his teeth into your leg. You have been bitten between the hedges, and this is serious respiratory distress. Make sure EMS is summoned in a timely fashion, supplemental oxygen, and the appropriate therapy. Some sideline gadgets that you might want to consider to make sure they're present for your sporting team are listed on this slide, and obviously many times it's a matter of the cost involved to determine what you can and can't have. Good news though is that the peak flow meter costs nothing hardly. Digital thermometers and the rectal thermometers now being promoted are not too expensive. Pulse oximetry, the fingertips have dramatically gone down in cost, as well as the AEDs. So consider adding these and having them all available to you during your sports trauma preparation. And finally, leaving you today, it's pretty much simple. The rule of 100 needs to be applied for the downed athlete. Make your decisions based on that rule of 100. If the rule of 100 is positive, trend the vital signs over 30 minutes at 5-minute intervals, redo the rule of 100, and you've got this formula for success. This formula for success is very important. You need to incorporate it. You've got to have the right team members, team physician, athletic trainers exposed to ATEC, EMS, either present or available to give the best possible team. And I would challenge you, if you have those pieces, if you have the dedicated athletic trainer in your community who's had a chance to attend and participate in these Andrew Institute focus sessions on sports trauma, together with a team physician with advanced skills and an EMS availability and commitment to the community for sports participation, you can provide the same type, the same character, the same excellence in care that's provided every fall on the NCAA Division I level at universities with far more resources and lots more money. Thanks for spending time today looking at sports trauma, in particular vital sign trending, to give you the information and the knowledge necessary to make the right decisions on your injured athletes. I wish you much success and hopeful for a successful sports medicine season.